I'm really thrilled to be able to introduce our last speaker for the afternoon. We have Michael Yudell with us, who is the Vice Dean and Professor in our own College of Health Solutions here at ASU. He's a public health scientist who focuses on history and ethics of public health and medicine, including projects on the history and ethics of genomic, history of race concept, the history of ethics, and autism research. He completed his PhD and MPH in social medical sciences at the Mailman School of Public Health at Columbia University. Dr. Yudell is the author of several books, including most recently Race Unmasked, Biology and Race in the 20th Century, winner of a 2016 Arthur J. Visselter Award from the American Public Health Association, along with Samuel K. Roberts. Yudell edits the Columbia Press series, Race, Inequity, and Health. This series combines work in history and social sciences and the biological sciences and public health to deepen our understanding. Hold on just a minute. Sorry, I have a sick kid at home. Okay, thanks for your patience. This biological sciences and public health to deepen our understanding on how ideological and scientific claims about race and race differences have impacted health and society historically and in the present day. He also conducts research on autism and ethics, including the National Science Foundation funded project examining ethics at community engaged autism research. With Dr. Emery Lucy, Yudell is writing A Way of Being Human, a history of autism spectrum disorders. And on a lighter note, as some of you may know, he also performs at Crossroads Comedy Theater and the long-running show Study Hall. Dr. Yudell presented with us last year, and we're just really grateful for him to continue to advance our understanding and discussions around ethics. Dr. Yudell, I'll take it away from you.
Thank you, Dr. Brunig. It's great to be here. Hope your kiddo is doing okay. Life in the Zoom world always has its surprises. So it's great to be back here. Last year, I spoke about some of the ethical issues relating to some other aspects of my research from a house that I was in the process literally of packing up and getting ready to move cross country from Philadelphia to here in the Arizona desert. And I will say it's been a great almost first year. It's great to be here in the greater Phoenix area and to be a part of the College of Health Solutions here at ASU as a professor and as the vice dean. So today I'm going to talk about newborn screening. And I'm going to share my slides in a second, but just by way of introduction of the topic, this is an issue that is professionally personal to me because when I left Pennsylvania, I stepped down as chair of the Pennsylvania Newborn Screening Technical Advisory Board, where we advise the Secretary of Health in the state of Pennsylvania on all matters relating to our newborn screening program, recommendations about which conditions to add, how to educate the public on newborn screening, and some of thinking together about some of the ethical challenges that I'm going to share with you that remain front and center in the newborn screening world across the United States and globally. So I'm going to share my screen, which I will do in a second. Okay, let's see, here we go. Screening slides, share. Okay, let me just do that. Okay, can everybody see that and hear me okay? Yes?
Yep, looks good.
All right, great. All right, newborn screening, a hidden public health success with some ethical challenges ahead. All right, so I'm going to take you through four broad areas this afternoon, and I'll probably talk for about 25 minutes, and we can have some time for discussion and questions. And then if I heard Meg right, I'm the last speaker of the afternoon. Give you guys some of your afternoon back, maybe. So we're going to talk about what is newborn screening, the history of newborn screening programs, some data about the successes of newborn screening programs, and some of the ethical challenges to newborn screening programs. Okay, there we go. So what is newborn screening? Newborn screening identifies conditions that can affect a child's long-term health or survival. Early detection, diagnosis, and intervention can prevent death or disability and enable children to reach their full potential. Each year, millions of babies, 4 million approximately, in the US are routinely screened using a few drops of blood from the newborn's heel for certain genetic, endocrine, and metabolic disorders, and are also tested for hearing loss and critical congenital heart defects prior to discharge from a hospital or birthing center. A little bit of history. PKU, or phenylketonuria, was the first newborn screening test in the 1960s. PKU is a rare metabolic disorder caused by a defect in the gene that creates an enzyme that breaks down the amino acid phenylalanine. If left untreated, PKU causes severe health problems, including intellectual disability, neurological problems, microcephaly, among other issues. PKU is treated with medical foods and modified diet immediately after diagnosis, leading to normal lives for PKU kids. The second test that came online more widely, newborn screening programs, was sickle cell anemia in the early 1970s. And from the 1970s to today, state-based newborn screening programs proliferated. And today, all 50 states, the District of Columbia and Puerto Rico, now have newborn screening programs. In 2002, the Recommended Uniform Screening Panel, or RUSP, was created by the US Department of Health and Human Services to create and curate a list of recommended newborn screening tests. And I'll talk a little bit more about the RUSP in a few minutes. And as I said, there are 4 million babies screened every year in the United States. Now, we can do newborn screening because it can be framed as a public health mandate. And here's the key point of why newborn screening is so successful, why it is in many ways, for most families and babies, an invisible program. And that's because we are screening for rare conditions that would otherwise be missed, and the early detection of can improve health outcomes and save the lives of babies. So 2 pieces to it. It's usually a rare condition that would be missed on the first physician visit or by a pediatrician in the hospital immediately after birth. We can only find these things by doing specific types of screens, and I'll talk in a little more detail about those different types of screens in a moment. But second, the screen can lead to improved health outcomes and save the lives of babies. And we'll use an example later of a disease that there's some controversy about adding to state newborn screening programs because the health outcomes remain unclear in the scientific literature. Now, each state ultimately chooses what it tests for, but as I said, it's based on guidance from the US Department of Health and Human Services and this thing called the RUSP. If a baby is screened positive, they will then receive a follow-up diagnostic test and be set up for treatment if that follow-up test is also positive. There are approximately, of the 4 million, and this is an important number, 2 numbers to think about, the 4 million babies tested, there are approximately 12,000 positive screens across the US that save babies' lives and improve health outcomes each year. Important to note, parents can opt out of newborn screening testing, but very few do. What does newborn screening screen for? Well, as I said, rare genetic and metabolic disorders, and this is done through blood spot screening that I'll show you how it's done in a moment. Critical congenital heart defects, or CCHDs, which are 7 types of heart defects that need intervention soon after birth. Pulse oximeter, that I'll show you a picture of in a moment on a baby's cute little foot, tests oxygenation in the blood. If it's below a certain number, the kid is referred for further testing, and surgery usually follows soon thereafter, or certainly within the first year of life. And then finally, there's a hearing test for hearing loss. So the newborn heel stick is the test that tests for rare genetic, endocrine, and metabolic disorders. And on the left, you can see a nurse applying the heel stick to a baby's heel. In the middle picture, you can see the little tiny bit of blood being squeezed out of that cute little foot. And then finally, the filter paper with those blood spots is drying on a rack and then will be sent to a laboratory to test for anywhere between 29 and over 60 different conditions. Second test, as I said, is the CCHD screening, which is the heart screening. And here's a pulse oximeter, a baby pulse oximeter on a baby's foot. Pulse oximeters have become more common in our lingo because of COVID, and you can buy little, finger pulse oximeters for people with COVID to have at home to be extra safe. And then a hearing test. Here's a newborn receiving their hearing test. If the tests show some or significant hearing loss, they are referred for further testing soon after discharge from the hospital. Criteria for newborn screening tests: that the condition can be detected 24 to 48 hours after birth, when it cannot usually be detected by a doctor's exam. It has a test that is specific and sensitive for the condition, meaning that a positive test is in all likelihood a positive test, and that a negative test is in all likelihood a negative test, so that we don't get false positives and negatives. And that its early detection, timely intervention, and effective treatment offer proven benefit. And this is a key point that we'll touch on in a few moments when we talk about some ethical issues. So this Department of Health and Human Services, RUSP, which is a list of disorders that the Secretary of the Department of Health recommends for states to screen as part of their state universal newborn screening programs. Disorders are chosen based on evidence that supports the potential net benefit of screening, the availability of states to screen for the disorder, and the availability of effective treatments. It is recommended that every newborn be screened for all disorders on the RUSP. Most states screen for the majority of disorders on the RUSP. Newer conditions are still in the process of adoption. Some states also screen for additional disorders. Although states ultimately determine what disorders their programs will screen for, the RUSP establishes a standardized list that has been supported by the Advisory Committee on Heritable Disorders in Newborns and Children, and is recommended by the Secretary of Health. So right now there are 35 recommended conditions on the RUSP. Not all states, as I said, test for all of these conditions. So what are some examples of RUSP conditions? One is maple syrup urine disease, very rare, 1 in 185,000 births. It's an inherited disorder in which the body is unable to produce certain protein building blocks or amino acids properly. The condition gets its name from the distinctive sweet odor of affected infants' urine. It is also characterized by poor feeding, vomiting, lack of energy, normal movements, and delayed development. If untreated, maple syrup urine disease can lead to seizures, coma, and eventually death. Second condition on the RUSP that we'll just introduce here, because we're going to circle back to it later, is Pompe disease. Pompe disease is an inherited disorder caused by the buildup of a complex sugar called glycogen in the body cells. The accumulation of glycogen in certain organs and tissues, especially muscles, impairs the ability to function normally. Researchers have described 3 types of Pompe disease, which differ in severity and the age at which they appear. These types are known as classic infantile onset, non-classic infantile onset, and late onset. The classic form begins within a few months of birth. Infants experience muscle weakness, poor muscle tone, and enlarged liver and heart defects. Affected infants may also fail to gain weight and grow at the expected, and they basically fail to thrive and have breathing problems. If untreated, this form of Pompe disease leads to death from heart failure in the first year of life. Also a very rare condition at 1 in 40,000 infants. Finally, critical congenital heart disease is a term that refers to a group of serious heart defects that are present from birth. These abnormalities result from problems with the formation of one or more parts of the heart during the early stages of embryonic development. CCHD prevents the heart from pumping blood effectively or reduces the amount of oxygen in the blood. As a result, organs and tissues do not receive enough oxygen, which can lead to organ damaging and life-threatening complications. Individuals with CCHD usually require surgery after birth, and that is slightly less rare at 18 in 10,000 infants. Here in Arizona, we screen for, I believe it's 29 conditions, broken down into these different categories: endocrine disorders, amino acid disorders, fatty acid oxidation disorders, organic acid disorders, hemoglobin disorders, a category for other disorders, and the disorders not detected by blood spot screening, which are hearing and CCHDs. So newborn screening, I am happy to report, as many of you may know, is a great public health success. Participation in newborn screening programs in the United States is greater than 99.99%. Very, very, very few families opt out. Most of the approximately 4 million babies born in the US are screened each year. As I said, 12,000 babies will be diagnosed with one of the core conditions each year. And NBS continues to be one of the most successful public health interventions, offering early detection and intervention to all infants, regardless of geographic, ethnic, or socioeconomic differences. It's really an amazing and important program. With interventions following newborn screening, babies are generally spared reduced life expectancy, disability, and death. For example, babies screened for SCID, or severe combined immunodeficiency, can receive and be cured by a bone marrow transplant for an otherwise fatal disease. Babies screened for congenital hypothyroidism prevents 160 intellectual disability cases every year, and babies born with CCHD can receive life-saving interventions. Newborn screening education is really important. This was one of the things that I worked hard to do with both politicians, advocacy groups, and the state government in Pennsylvania when I was the chair of the Newborn Screening Technical Advisory Board there. As I've said, one of the challenges of newborn screenings is that it is largely an invisible program despite its successes. Most parents are unaware of the program and even of the fact that their baby has been tested. You know, newborn parents are out of it. They're tired. They're not paying close attention. They may not have gotten a pamphlet in advance of the birth or during the birth. Following the birth, they may get a ton of pamphlets that I can tell you, in my experience, went pretty much right into the recycle bin. So people are unaware of the program. And unfortunately, people generally learn of the program if a screen is positive and a diagnostic test and follow-up is required. And as newborn screening programs have evolved, as we'll talk about in a few moments, I believe there's an obligation for more public education, especially in the few states where the blood spot samples that you saw earlier can be used for research. So let's jump into some ethical issues. One is the storage of blood spots. State newborn screening stored dried blood spot samples on the original filter paper for varying amounts of time. The blood spots can be used by the programs for quality control. They can be used to demonstrate the utility of blood spots for other potential newborn screening program efforts. They can be used, and this is very important, retrospectively to test when a condition is added to the mandated test, or in the rare occasion when there is a false negative, and you go back and you can look at that baby's test and do a follow-up test. They're used as part of research to develop new screening markers for new tests. And in some states, they can be used for genetic and public health research. The storage of dry blood spots varies state by state. Many states will throw them out within a few months. Some states store dried blood spots indefinitely. So here's a challenge ethically. Newborn screening is an opt-out program, so the storage of residual dried blood spots is done without informed consent. And as I said, the length of storage varies by state. Now, federal regulations allow de-identified residual dried blood spots to be used in research, and the use of dried blood spots in research is increasing. One recent study found that the majority of studies identified did not report whether dried blood spots were identified or de-identified and whether consent or parent permission was obtained. Given the controversy over research uses of residual dried blood spots, this is Rothwell et al. A few years ago, we encourage investigators in this domain to document elements relevant to human subject protections. So really important moving forward as the storage of these dried blood spots potentially have research, more and more research uses, that we think about going back and making sure that we are consenting, always consenting, when any identifiable data is used. That is really essential. Ethical issue number two. determining which tests to add. So the RUSP has a formal process to recommend and add new newborn screening tests to the testing panel. A nomination package is submitted by medical advocacy and professional organizations and individuals. The proposed condition must have a validated laboratory test, confirmatory testing with a sensitive and specific diagnostic test. Must have data showing the efficacy of the intervention. Then an evidence-based review group completes a systematic evidence-based review, provides updates, and presents a final report. And then a decision matrix is used to make the final RUSP recommendation. Now, recently, state and parent groups have successfully pushed to add conditions to the state newborn screening programs against the recommendation of both the RUSP and the state-based newborn screening programs and their advisory boards. And this is just an image of the RUSP decision-making matrix, which relates to whether there's benefit, feasibility, and whether programs are ready. You could take a look for a moment at this matrix, and the best, of course, is the program is ready to test. That the screening for the condition has high certainty of benefits, and all the way down to there's low certainty regarding the potential net benefit of screening. So the RUSP, the members of the Advisory Committee on Heritable Disorders and Newborns and Children will use this as they make their decisions and they analyze the data they collect. So I want to talk about one brief example that I had some experience with, was with Krabbe disease. And this was about 7 years ago. I sat this was when I was the co-chair of the advisory board. I sat with Dr. Rachel Levine, who was then the Secretary of Health of Pennsylvania, and testified before a committee in the Pennsylvania State House, making the argument that Krabbe disease at the time, because treatment was of questionable efficacy, was not ready to be added to the panel. A group of parents came and challenged us, and it was very difficult. A mom who I have since become, gotten to know really well and become friendly with, came in and told her story. And her story included coming in with a giant 4-foot blow up picture of her now deceased baby, who sadly died of Krabbe disease. And her argument was, even if there's a small chance of success to save my baby's life through bone marrow transplantation, then we should be screening for it to save babies like hers. We went back and forth with the state government, and eventually added Krabbe disease to our screening panel. We could do that in Pennsylvania because we had the laboratory sophistication to accurately test for Krabbe disease. There are challenges with the sensitivity and specificity of the earlier tests for Krabbe. We were able to mostly overcome that. And we also have the ability to get kids bone marrow transplants, which is the best treatment right now for Krabbe disease in Pennsylvania. So we went ahead and added it. But let me just tell you a little bit more about Krabbe disease. It is a rare and devastating neurodegenerative disorder caused by mutations in the GALC gene, resulting in increased accumulation of a galactosylcerebroside. Sorry, I always butcher that. In the brain, which leads to a loss of myelin and nerve damage. There is no curative treatment. Bone marrow transplant can improve and lengthen the quality of life for KD kids. Only 9 states currently screen for KD. Arizona does not. The RUSP did not recommend Krabbe disease screening because of challenges distinguishing between infantile and later onset forms. It can be difficult, even with a positive screen, when and if disease will develop. There are equity concerns both within and between states for access to bone marrow transplantation. And then there's the question of the efficacy of bone marrow transplantation for kids with Krabbe disease. One interesting case recently was the Commonwealth of Virginia making a decision differently than Pennsylvania, which decided not to add KD to their MBS panel. And their rationale included that there were no stem cell centers in Virginia, and babies need stem cell transplant within the first 30 days of life for this to be successful. There were financial concerns about the impact of this type of screening on the overall NBS program, and there were equity concerns. For example, for Medicaid patients, getting approved for bone marrow transplant out of state can take months. Moving on, ethical issue number 3, how about late onset conditions? Do they violate newborn screening's public health mandate? So newborn screening is a public health intervention with an opt-out consent based on identifying diseases that require treatment at or shortly after birth. That's the public interest. We save lives and we save the state, money in insurance, which is why these programs can go ahead. Now, here's an interesting challenge. Pompe disease, which is an autosomal recessive lysosomal storage disorder, can have a late onset course, which forces us to consider the potential impact of sharing this type of information with parents and its impact on the children tested. Now, this is a recommended condition because there are good interventions for kids with early onset or infantile Pompe. But there are some ethical challenges. And should the calculus change if we're telling parents that their child's condition might not appear until adolescence or later? In such cases, are we interfering with a family's autonomy by conducting such tests? How might the child's identity be altered by conducting such tests? Might that child and their family face stigma or discrimination based on a diagnosis that could be far in the future? And might a family seek to take an action contrary to the child's interest because of a late onset diagnosis? Those are some of the challenges with what are increasingly complex tests that are being proposed for newborn screening. And finally, the final ethical issue is about consent in the genomic era. So with new genomic technologies like exome screening and genome sequencing, do they have a place in newborn screening programs? Is this a move towards precision public health, as it's been called? And will this put newborn screening programs at risk by a public who may get results like, well, your kid is fine now, but they may develop condition X, Y, or Z later in life? Will parents not want that kind of information? Will the kids who were tested not want that information later in life? For those of you who've seen the movie Gattaca, which I recently discovered is now streaming on Netflix, the beginning of that movie, there's a scene where baby's born, they do their version of the newborn screen, and there's a printout with all sorts of different types of risk for different types of conditions. And is that what we want to create here? So are technologies like these beyond the public health mandate? What are the psychosocial impact on babies and families for tests like this? How about the potential for identification or return of results for variants of unknown significance? Meaning there's a gene variant, it's not the standard gene variant for a particular condition. We don't know what it's going to do to your kid, but here's the result anyhow. And when do you share information that may only have meaning later in life? And ultimately, if a genome sequence is used, do we need to alter the opt-out nature of newborn screening? So perhaps you could have a 2-tiered newborn screening system. One is, the public health mandated newborn screening, and then an opt-in for additional genome and or exome screening. And then finally, do national and or international norms need to be created for the use of genomic technologies in newborn screening programs? And that's the cutting edge of newborn screening right now. So I will stop there. Thank you for listening. I'm going to stop sharing my screen, and I am happy to answer questions. And I see one question in the chat box already from Kaylee Menke about tests playing. What about home births and midwives? And yes, midwives are involved in newborn screening. If they do not do it, the pediatrician will offer newborn screening. In Pennsylvania, because of our rural population, particularly for Amish and Mennonite populations who generally do not end up in hospitals, midwives were very important to be on the front line. I suspect that in rural communities here, in Arizona face some of those same issues.
Michael, there's another question about how will we address information security for the whole genome sequencing?
Yeah, I mean, I think this is a challenge for whole genome sequencing in and outside of newborn screening. And frankly, people are right now paying about $79 to places like 23andMe and Ancestry.com and giving away their whole genomes. So I think it's really important that the types of security and firewalls are built for newborn screening programs when genetic data, if and when genetic data is ever uploaded. But we also, like I said, live in a society where people constantly give away their information, be it biological or their Facebook information or their phones tracking them. So we'll see how this develops and evolve over time, and whether there's real pushback against these types of issues. Another question from Corey Wisner: if parents opt out of testing because they don't want to cause their baby pain with a heel stick, why couldn't cord blood be drawn after delivery for testing and use? I don't know the answer to that question. I do know that it is commonplace for the heel stick, and that again, very few people opt out because of that reason. And another question from Kate Dobler: there are some states that do a follow-up screen at 2 weeks to confirm results. Pennsylvania was not one of them. Arizona is. So it varies by state.
Sorry, the chat's going today.
That's right. I'm just going to take a sip of my water. Hold on.
So the question is it because it has to be drawn 24 hours after birth, or does that play into it relating to cord blood question?
I don't know if it's a question of the sample itself or the infrastructure that has already been built to collect dried blood spots in the way that it's collected. So not really sure.
I'm wondering if you could talk through best practices and consent around all of these issues, particularly, sometimes birth can be a traumatic event for some, and when is it best and how is it best done, particularly as these emerging issues are coming forward?
Yeah, so best practice right now is opt out. And I think that newborn screening programs, or let me say that researchers are flirting with pushing newborn screening programs to bend the current public health mandate that I described. If that happens, then I think there will need to be a more in-depth review of the opt-out consent practice. I think for those states that use newborn screening filter paper dried blood spot samples in research, there is rigorous consent, although clearly based on some studies that is not always effective. And the best practice, of course, is informed consent and going back to families if any de-identified data is used. If the data is de-identified, consent is currently not needed in most states, although some states will require you to go back. Again, we're talking a very small sample size right now. So, but from a public health perspective, those samples could be very, very relevant. This is like every baby born, you can do environmental and toxicological testing at birth. You could look at incidents for a range of conditions that we currently don't look at, by both looking at environmental exposures in the blood and also gene variants. So it's a very, very rich database that goes underutilized for good reason, because there is a concern that if research proliferates, that there could be some pushback. Now, I say this, given the strange public health time in which we're living. 4 years ago, before the pandemic, I would have been much more comfortable pushing a research agenda for dried blood spot samples, and saying to the public, hey, this is in the interest of the public's health. We really should be utilizing these samples to understand gene environment impact in babies, and we can do incredible studies. Now, I'm concerned that the political or the politicization of public health would suggest to me that now would not be the best time to push a research agenda with these kinds of samples. There was a lawsuit in Minnesota probably about 10 years ago. Some parents had figured out that the samples were being used for research, and that was, I don't remember if it was completely stopped or it was certainly altered in that state. So there are folks out there who are aware of this, and they can be some of the same people as some of the anti-vaccine folks as well. Other questions?
To see how that plays out in Arizona, just given some of the history using genetic material for research for which consent wasn't provided. So
yes, and I was disappointed to see that Arizona, unlike Pennsylvania, does not require an ethicist to sit on their newborn screening advisory board. So
there may be folks on this meeting that sit on that board. So maybe a plug for that.
Yep, definitely a plug for that.
Well, Dr. Yudell, thank you so much for joining us. I think this was really interesting questions that you posed and things for us to think about as we continue our maternal child health practice. Oh, there's one more question. Sorry, Kate. Does Arizona report out our NSB rate?
Yeah, I believe each state does. We would have to go to the Arizona website to look specifically at that. States are pretty good about reporting. Yeah, let me drop it in the chat, the website.
And there are folks on the call from Title V and Arizona Department of Health Services. So if you know the answer, feel free to chime in. With that, we will give you about 20 minutes back to your day. Thank you all for joining us. Tomorrow we are starting bright and early again at 8:30, and we will be kicking off with a talk on climate change and how it affects maternal child health populations. Then another interactive session from Strategic Diversity Initiative and FIBS, and Caitlin Dressler will be talking about hierarchical issues as it relates to class and in diversity, equity, inclusion. And then we'll have another round robin of abstracts and then a poster session. We hope you enjoyed today and that you'll be back tomorrow.